Hello, everybody. So today we are going to be talking about OMT for asthma and COPD. And as we've done in our previous sessions, we're going to go over some go-to techniques that we can use for these conditions. So for those of you who don't know me, my name is Alyssa Stile. I'm one of the third-year family medicine residents here at Abington Family Medicine. So to begin with, I wanted to go over some epidemiology and some statistics. These are taken straight off of the CDC website. So, as we all know, chronic lung diseases are a major problem in this country. They are a large part of what we see in our outpatient office and a large part of our hospital admissions. So, just to have some concrete statistics, I've listed them here. Chronic lower respiratory disease is the fourth leading cause of death in the United States. Um, for ER visits that have listed COPD as a primary diagnosis, this is the most current data, 923,000. It comprises 5.7 million outpatient physician office visits, and that's specifically for COPD as a primary diagnosis. Some of the asthma statistics are from a couple years ago, but this is the most recent that I saw on the CDC website. In 2005, they quoted that 22.2 million people had asthma and 12.2 million people had at least one asthma exacerbation in the previous year. In 2004, here are some additional statistics that I won't go through all of them, but as you can see, they, as I said before, they are a large part of our visits that we are seeing in the outpatient office, and hopefully today we'll have some refreshers on some OMT techniques that we can use to help our patients feel better with these diagnoses. So to start out, I just put a reminder of our structural exam. Some things to think about specifically for COPD and asthma are specific musculoskeletal disorders like scoliosis that can definitely affect lung capacity. People with severe kyphosis can definitely affect the way that we breathe and our lung expansion. So that's something to note when we start off our diagnostic exam with our structural exam. The next slide is just, again, a reminder. Our respiratory system is T2 to T7. So when we're thinking about our viscerosomatic reflexes and, our techniques that we want to target a certain area for respiratory system, we're thinking upper thoracic. So I'm going to go through a couple techniques, and just as kind of an overview, these techniques, I started out with the parasympathetic, and then, Luna's saying hello in the background, parasympathetic technique, and then I'm going to go through some other techniques that can really open up different areas of restriction that can help facilitate lymphatic flow. So to start off, I thought it would be good to talk about, again, we always like to start off with parasympathetic technique. And this is upper thoracic rib bracing. So a lot of us are used to doing the lower thoracic area on the side of the table. Again, targeting the lower thoracic. But I thought this was an interesting one to focus on the upper thoracic region. And for each technique, I put indications and contraindications because that's always important to keep in mind. So you can read those on your own. But so with this technique, I'll try to kind of show with my hands on the video, but it's really going to be a gentle traction upward, and you can really use your body to lean in and focusing on the areas next to the rib cage where the sympathetic ganglia sit, and that's really what we're targeting. The next technique is thoracic inlet and outlet, myofascial release. Again, this is and you can start out with this one if you would like, just to get the patient comfortable and to really, again, open up those areas of restriction. but again, I like to start off with parasympathetic techniques, but you could do whatever feels comfortable for you. And then for this technique, you put your hands on sort of the trapezius area, and you want to find either an area of restriction. So you can do indirect, actually, or direct. I'm sorry. You can do either go in the area of restriction or ease, and be consistent with it. So forward, backward, side to side, counterclockwise, clockwise, and you want to hold in that area until you feel that myofascial release. The next technique that I wanted to talk about is, again, opening up areas of restriction to help people. And again, specifically with asthma and COPD, they have a lot of infections. Infections can be a trigger for them in terms of respiratory infections. So we really want to facilitate that drainage. So for the pectoral traction, basically what you do is you place your hands under the axilla area and pull cephalad, and you can use, as the patient inhales and exhales, you can use that. You can use the patient's respiratory effort to help with opening up that area. So as the patient takes a deep breath, you can lean back, and then as they exhale, you would resist. And then again, inhale, you're pulling back on that axilla area. Okay, and so for the next technique, it is called doming of the diaphragm. So the patient is laying supine, and for most of these techniques, by the way, I should have mentioned, knees are flexed and flat on the table. And so for this technique, the physician stands next to the patient and places their thenar eminence right below the xiphoid process. And the patient is instructed to inhale and exhale several times. And when the patient inhales, the physician is actually resisting the motion of inhalation. And when the patient exhales, we are following the motion of exhalation posterior and cephalad. And again, you repeat this a number of times. So just to clarify, thumbs below xiphoid process with hands, the rest of the ear digits around the rib cage. And we are resisting inhalation. So when the patient takes a deep breath, we're resisting that. And when they're exhaling, we are pushing towards the back and up. And if we go to the next slide, I think it's maybe easier to visualize what we are trying to do. So you can see where our thumbs are below the xiphoid process is, and you see there is a label vertebral attachment of diaphragm below that. So that's kind of the motion. That's exactly where anatomically we are aiming for. So when we are pushing posterior and cephalad, it's right kind of above that diaphragm, and in the hope of expanding the lungs. And let's see. So the next and last technique that I have listed here is the thoracic lymphatic pump, and I thought that this one would be a good one to end with. So after we've kind of opened up any restrictions, we can do a lymphatic pump to again facilitate the lymph flow. So let me go to this slide. Okay. So for this technique, again, the patient is lying supine, and the knees are flexed with feet flat on the table, again, like most of the techniques that we went over today. So for this technique, the physician will be at the head of the table behind the patient's head, and they will place their thenar eminences kind of right inferior to the clavicles, right over the upper chest. For females, to make them more comfortable, you can have females put their hands on their chest, and then the physician can place their hands on top of the patient's hands, just so to make them comfortable, since the area that we are working on is right over the breasts. So that's an option that I would definitely recommend. So for this technique, the patient is instructed to take a deep breath and exhale. So inhale and exhale. And for this technique, during the exhalation, the physician will put more pressure on the rib cage. And when they're inhaling, you're kind of resisting the inhalation and pressing down on exhalation. And then so again, you can do this cycle for several times, maybe about 3 or 4 times. And on the last time you tell the patient to inhale, the physician will suddenly release their hands, and that kind of facilitates a very deep inhalation and can open up areas of atelectasis, and again, with that goal of increasing lymph flow. So I think that will be a good technique to end on for your patients. For asthma and COPD. For asthma and COPD, there are some other techniques that I listed on the next slide to consider that I didn't go over today. Again, just wanted to keep it focused and something easy for you guys to remember. But some other things you can think about is an ENT sequence, especially for a lot of our asthma patients who have who their triggers are URIs. This will be a good technique to help those patients out. We can focus also on lower thoracic rib bracing that I mentioned before, muscle energy in the thoracic area, HVLA in the thoracic area. So I didn't really touch on those techniques, but if you have them in those techniques in your pocket that are easily accessible for you to use on your patients, I would definitely encourage that. To go over billing, so I placed in bold what would be applicable for today. So we really focus on the thoracic region, and you always want to have a diagnosis, so thoracic somatic dysfunction, and remembering TART, tissue texture changes, asymmetry, restriction and range of motion, and tenderness. So those are your 4 components that you want to document in your HPI portion, and then use thoracic somatic dysfunction as your diagnostic code. Just a reminder, you have to have one of our osteopathic attendings to be present to bill. So if you were performing a diagnostic, if you made a diagnosis during the visit, and in addition perform treatment, then you would use that diagnosis code, a 25 modifier, and then use the CPT code for your treatment. If you previously diagnosed your patient in another visit and they are coming here just for treatment, and you already know what the issue or the problem is, then you would only use the CPT code. So we bill by regions. In this area, I felt that we really focused on thoracic and rib cage. I guess you could also consider visceral as well. And you could really easily reach the next level for 3 to 4 diagnoses. If you do maybe some soft tissue on the cervical region, or you do suboccipital release for another parasympathetic technique to add to this regimen, you could easily go to an additional area for the CPT codes. Here are my references. Hopefully you all enjoyed this. This will be, it's not an in-person, hands-on session like we've had previously due to the current times, but hopefully this will provide you guys with, again, some go-to techniques for asthma and COPD that you can use to help our patients in our office.